Great. Thank you all. I assume you can hear me. And sorry I'm not there in person, but yeah, it's a pleasure to be able to present today. And what I'm going to talk about are the increased risk of GI and other cancers in people with CF. On this slide are my disclosures. I have no conflicts of interest, and you can see I'm funded from federal sources as well as pharma and biotech foundations and philanthropy here, and also work on developing and scaling up healthcare delivery models with a prior president, as you can see there. So what I'm going to do on this journey today is I'm going to talk about these four different spheres. First of all, talking about it, as you heard from Dr. Euler and others, on CF and aging. And this is actually an exciting, very positive time where we're able to recalibrate, to think about being geriatric specialists with our patients who have CF. But with that comes some downsides. And I'll focus my presentation on this increased risk of cancers in CF. A lot of focus will be on the GI tract cancers, but I'll talk about other cancers. And the question is, why do we have this increased risk here? Who should we be screening? When should we be screening here so that we can stay ahead of things and pick up lesions when they're in their precancerous state rather than when they're already in overt cancer? And I'll dive into that. I'll then talk about whether or not the biologic behavior of these cancers in the setting of CF, are they the same behavior as what we see in the general population? And we're now, unfortunately, having clinical clues that, in fact, it's a different biologic behavior, that these tumors that form in the setting of CF may be more aggressive, occurring at a younger age here. And then lastly, I'll focus on treatment strategies. How can we prevent the development of cancers? How is that treatment informed by science? And I'll share some early research that looks very positive here. What's the role of surgery, chemotherapy agents? But also importantly, we don't want to be scaring individuals, but rather to have a thoughtful approach and how we can be proactive in trying to mitigate this increased risk of cancers. So let's start off by talking about why is there a cancer risk in CF? And it's clearly multifactorial. We know if you just look at colon cancer risk in the general population, that our high saturated fat Western diets are a big driver of an increased risk of colon and rectal cancer. And for the longest time, until we now have more highly effective modulators, we were advocating for very high fat diets in our patients with CF to keep up their weight, to keep up their nutrition, so that that would help with lung function. But as you're going to hear, that's been kind of a two-sided sword here, where these high saturated fat diets put individuals at risk for GI tract cancers. Another driver is this dysbiosis, these abnormal bacteria in the gut. We know that plays a role in driving colon cancer risk. Same thing with chronic inflammation. Tumors love to be in an inflammatory environment. And that inflammatory environment actually feeds cells to become malignant, to become more aggressive in their growth. And then lastly, turns out the CFTR gene is what we would call an anti-oncogene. It's an anti-cancer gene. And there's been some very eloquent work, and I have this cartoon on the right side here, that normally CFTR, the CF chloride channel, interacts with this protein called PTEN, PTEN. PTEN actually helps get rid of Pseudomonas on your cell surface, which is internalized. PTEN puts the brakes on the inflammatory response system, putting the brakes on something called NF-kappa B, which forms IL-1, IL-6, IL-8, the messengers that turn on inflammation in the body. And if you look at what a CFTR dysfunction does, so if you lose CFTR normal function, you'll have less of this PTEN. And as a result, you'll have increased inflammation. You've taken the brakes off NF-kappa B, and you're forming these inflammatory driving cytokines. You'll have decreased intracellular Pseudomonas killing. Not quite clear the mechanism, but in part is this kind of endosome lysosome fusion where you bring in Pseudomonas and internalize it, but you're losing the killing effect when you bring it inside a cell. And pertinent to my presentation, if you lose PTEN, this is a tumor suppressor gene, well described, well studied by many, many other groups. And their work outside of CF, so just in the normal population, if you look at individuals who have PTEN mutations or other causes for losing PTEN, that these folks have earlier onset of cancers, much poorer survival, much more aggressive cancer growth and metastases. And what are the cancers that are typically seen when you lose PTEN function in the general population? You see breast, colon, and lung cancer. And what I'm going to go through is that's kind of what we see in CF. So perhaps a lot of this increased cancer risk in CF may be at least in part due to this also concomitant loss in this PTEN tumor suppressor gene. So let's start with colon cancer. Who's going to get it in the setting of CF? When? How should we screen? And in individuals with CF, there was a sentinel study done a few years ago. And by the way, I'm putting references on the bottom right of each of my slides. And at the University of Minnesota, they took 88 individuals. They were around age 40. They had no overt GI symptoms, and they underwent a screening colonoscopy. So what did they find? They found that 50% of patients had adenomas. Adenoma polyps are the type that if you leave them in, potentially turn into cancer of the colon. So half the population, first screen, no symptoms, already had these adenomas. 25% of the individuals had advanced adenomas. Those are almost guaranteed to progress on to the sequence of adenocarcinoma. So extraordinary number. And 3% of individuals with no symptoms at that first screening colonoscopy already had adenocarcinoma of the colon cancer. And if you look at all the studies that have been done thus far, overall, it tells us that there's a sevenfold increased risk of colorectal cancer in our CF population. It goes up to 27-fold if you've undergone prior transplantation, like a lung transplant, presumably because of the immunosuppressive drugs that our individuals are put on. As a result of these data, the CF Foundation originally came out with their colonoscopy guidelines that everyone by age 40 should have a screening colonoscopy. If you've had a transplant age 30 or 2 years after transplant. But if you look at the data from Minnesota, people were already developing cancer. So 40 is probably too late. At Boston Children's Hospital and Brigham Women's Adult CF Center that I'm part of, under Dr. Euler's direction, we start screening in your 30s. And we're finding already significant adenomas, advanced adenomas. So probably age 30 is probably the right time to be thinking about this. I've helped lead with Sarah Jane Schwarzenberg, Christine Hacham, the NICE CF study. We asked the question, what if we did like a second generation modified Cologuard assay and microscopic testing for blood in a stool sample? Would that predict having polyps at colonoscopy? We've just completed the study. The data will be presented at the North American CF meeting by Dr. Hacham, and you'll see those results. We've also, in that study, asked the question, if you're on a highly effective modulator, does that change these numbers that they saw at the University of Minnesota? She'll present that data. But the bottom line is not having much effect on this cancer risk. So unfortunately, not going away despite highly effective modulators. If you look at other GI tract cancers, gallbladder cancer is up at least threefold. Similar numbers with pancreatic cancer. And what we're seeing across the country is that our aging CF population, when they hit their mid 50s, that's when we're starting to see these pancreatic cancers developing here. And it's brought up the question, should we start screening with an MRI test that looks non-invasively at your pancreas? That's actually quite sensitive, called MRCP. Should we do that by age 50? And should we do that every year, every 2 years? How often should we do that? And again, with Dr. Euler and our team, we're looking at our data, whether or not that's an effective strategy here. So is there a gene dosing effect? By that I mean, well, if you're healthy, you have normal CFTR. If you have overt CF, you have a severe gene dosing effect here, severe dysfunction of the CFTR chloride channel. If you're a carrier, you're probably somewhere in the middle, so an intermediate gene dosing effect. And does that give you an intermediate cancer risk? The answer is yes. And I've cited the PNAS paper in 2020. They looked at carriers and they saw that there was an intermediate risk. So colon cancer was up 1.8-fold over the general population, pancreas cancer around twofold. And so should we be focusing on carriers, parents of individuals with CF? Should they undergo more aggressive screening? And what about what we see in the news now all the time? Younger and younger patients presenting with colon cancer, pancreatic cancer, breast cancer. Are these carriers? So my team, we're starting to actually look at that. At our institution at Beth Israel Deaconess Medical Center, our genetic counselors, when they pick up that someone is a CF carrier, they're actually automatically referred to me. And I'm now doing screening colonoscopies at a young age or MRI screening and collecting that data. But I can tell you, doing these colonoscopies on these carriers in their 30s, we're finding significant polyps. So we'll see more dedicated tracking of the data. I'll mention, and this is public, I was not involved in care, but there are parents out there such as Joe O'Donnell, who was a great philanthropist and fundraiser for cystic fibrosis care. He died from pancreatic cancer, a parent. Was that preventable if he was undergoing MRI surveillance with this kind of knowledge? Perhaps. So something we should be kind of focusing on. What about other cancers? There's a UK study showing breast cancer is up approximately threefold. Cervical cancer also up. And about a third of those patients with cervical cancer with a mean age of 32, a third of them have HPV, suggesting that if we did HPV vaccination, that maybe that will help prevent this increased cervical cancer risk. Lung cancer up to fivefold, which goes to 40-fold after lung transplantation, and perhaps lymphomas, both Hodgkin and non-Hodgkin, are up. So what should we do with screening? Mammography, MRI, more aggressive screening than in the general population, and including what do we do in carriers? Cervical cancer, more aggressive HPV testing and vaccination, making sure everyone's vaccinated. We're starting to see head and neck cancers. Those are usually HPV driven as well. So one more target to think about. And pap smear testing. How do we screen and when for lung cancer? The bottom line is, I'm very involved being a pancreas person in lots of screening strategies. And we're now fused with the Dana-Farber Cancer Center and with Beth Israel Deaconess Medical Center. So we do lots of high-risk screening. CF and CF carriers is nowhere on the radar screen. And I think not panicking people, but rather we should be really thinking about just considering this another high-risk cancer syndrome. And who's going to make sure all this screening is done? This is not, I think, a simple answer. Is it the CF team? Is it the transplant team? You've been transplanted, your primary care doc? Who's providing all that care? And I think that's important to be looking at. And I know the CF Foundation is looking carefully at this, including with Whitney Brown's leadership here. And why is it that if you had a transplant, your risk goes through the roof here? We know that these cancers develop after about 3.9 years after getting a transplant. Maybe it's closer surveillance, immunosuppression, more severe phenotype, maybe greater abnormal bacteria. There's dysbiosis. They're not always on highly effective CFTR modulators. We know at a basic science level, I put on the right side of the screen, there's lots of abnormal cellular processes going on when the way cells are talking that's leaving cells like uncontrolled in their perhaps growth pattern here. So that takes us to our next part is what's the biologic behavior if this is a cancer in the setting of CFTR dysfunction, the setting of CF here? And maybe we have clues from one patient that I was caring for with Dr. Euler. And this is the power of an N of one. And for anyone who's a researcher or clinician, just keeping your eyes open, are there maybe some clues in front of you? This was a gentleman in his mid-50s, developed a 2.5 centimeter pancreatic head mass. It was 50% abutting the portal vein, so potentially resectable with surgery, but he got 6 cycles FOLFIRINOX followed by a Whipple procedure to remove that head of the pancreas and everything around it. That's generally now this more standard approach. He had a CAT scan 3 weeks later, and what was thought to maybe be a curative surgery, he now had cancer everywhere and had a rapid downward course. So I've been doing this for about 34 years. I've never seen a presentation like this. Is this kind of the canary in the mine, and it's telling us about the biology of tumors in the setting of CF? What could be the mechanism? And if you step back, prior to 1970s, it was thought that what a cancer was going to do was solely driven by the cancer itself. Was it going to grow fast, spread, etc.? And Judah Folkman in the 1970s said, it's not just what the cancer its cells themselves are doing, but it's everything around them called the stroma, that environment. That in part dictated the growth of a tumor and its spread. And today, this has been now expanded, this model. That stroma, what's around a tumor or cancer, is also driven by endothelial cells, fibroblasts. Inflammatory cells are a big driver of cancer, as I mentioned earlier here. And we know cytokines. The more you have these inflammatory mediators, these cytokines, tumors love this and it drives them. Without being too political, it's kind of like if you look in Washington. By the way, I'm from a blue state here, but without saying who I like or don't like, Washington, it seems that an inflammatory environment drives the rhetoric, whether it's Democrat or Republican now. And tumor cells are the same. They love an inflammatory environment. And in part, this inflammatory environment, we know it's driven by these called resolvins or small lipid molecules called SPMs that I'll talk about in a moment, specialized pro-resolving mediators. They shut off inflammation. They turn off rapid cell growth here and make cells differentiate into organs and be more controlled in their cell growth. And there's a fair amount of data now that although these SPMs, these resolving mediators, they decrease inflammation, control cell proliferation, it looks like cancers shut off these SPMs so that they can now become immortal, spread, and do their thing. So one more background slide, and then I'm going to show you a couple of data slides that I think may be telling us about biology, but also how we can screen and potentially decrease this risk of cancers. So if I was there live and I injected someone with stool underneath their skin. First of all, I think you'd be really pissed off at me if I did that. But what would happen? Your body would say, some stool and bugs underneath the skin. Let's attack it. There would be swelling. Your white blood cells come in, and there would be this activation where on the right side here, arachidonic acid through the COX-1 and 2 forms all these prostaglandins, and you just attack whatever's foreign there and you get rid of it. And about 6 hours later, it's all over. But you got to shut it off. If you don't shut it off, that inflammation will just keep going, and then you'll get chronic inflammation. Turns out the body has this lipid-mediated class switching. Charlie Serhan at the Brigham, one of my collaborators, was the leader to first describe this. And what happens is that all of a sudden you switch. Arachidonic acid now switches from prostaglandins to forming these lipoxins that shut off and resolve inflammation. These two components of fish oil, EPA, DHA, form these resolvins, the E series, D series, protectins, maressins. All of these rapidly shut off inflammation, activate macrophages to heal everything up, and just stop. They stop this whole process. And there's lots of data from many groups now that these SPMs, specialized pro-resolving mediators, these resolvins, protectins, maressins, they do lots of things, and now there's lots of clinical trials ongoing. They resolve inflammation through their effects on T cells, B cells, natural killer cells, neutrophils, macrophages. They help in pain through activation of these maressins. They engage wound healing and tissue regeneration. In the brain, they play a major role in neuroprotection, and they actually help in bone formation and play a role in host defenses. But in cancers, they may play a very sentinel role. So in work that I do with Deepak Panigrahi, his picture is with me on the right side here. He's in pathology, actually trained with Judah Folkman. He's been looking at why is it a subset of patients who get chemotherapy, their cancers actually take off, goes in the wrong direction. And these are patients where there's only partial killing of their tumor cells, and then all of a sudden their tumors seem to explode and grow everywhere, and then the patient has a rapid death. Kind of like what we're seeing in that patient I described earlier with CF and pancreatic cancer. And what Deepak has shown, if we look at this here, he takes cancer cells. And for example, if you take cancer cells, you inject them under the skin in a mouse, cancer cells grow. And this is after 30 days, 40 days, cancer cells starting to grow here. This is pancreatic cancer. This is melanoma, lung, lymphoma here. They're kind of puttering along. If you now take these cells and you kill about 70, 80% of them with chemotherapy, and now inject into the mouse not only the living cancer cells, but the dead cells from incubating with chemo. What happens is these cells, here's pancreatic cancer cells, they take off. Tumor volume goes from about 700 to it's now about 2,200. Same thing, not only pancreatic cancer, melanoma, lung, lymphoma. Take off here. And if you look at the animals surviving just pancreatic cancer cells alone, about 80% of the animals die by 45 days of age. If instead you inject pancreatic cancer cells with some of these dead cells generated by chemotherapy, all the animals are dead by 40 days. Dramatic response. And the model he's come up with that other people have now confirmed is that if you have tumor cells incubating with chemotherapy, or you give chemotherapy to a patient, yeah, you're going to get dead cells. If you don't get rid of all the tumor cells, these dead cells incite this inflammatory response, activates all these inflammatory mediators. Tumor cells now actually have enhanced growth and bad outcome as a result. So how do we stop that? And how do tumor cells do this? I mentioned all that these inflammatory mediators go up. So now he's taken, again, pancreatic cancer cells, mix them with some of the dead cells. Here is their growth. It's very accelerated. You incubate basically the cells or give to the animal. Chemotherapy doesn't have much effect on the cancer cells. If you give dexamethasone and kind of anti-inflammatory, the pancreatic cancer cells are still growing. If you now give the resolvins, D1, D2, or E1, that normally resolve inflammation, decrease cell proliferation, the pancreatic cancer cells barely grow in the mouse. So very exciting that maybe this is a way of treating here. And maybe very low resolvin levels help predict, is someone going on to cancer? I have a study going on in that in the general population. It looks like that's holding true. And we have patients with various precancerous lesions going to cancer. We have their blood over time. And as their precancerous lesions are progressing, resolvin levels are going down and at their lowest when the patient develops an overt pancreatic cancer. So we may have a blood test that helps predict, at least for pancreatic cancer development. So we can augment this pancreatic, these cancer mechanisms in CF that, sure, maybe they're at high risk because of loss of the CFTR anti-oncogene, abnormal bugs. There's increased inflammation compared to the general population. In part, this is driven by increased levels of this arachidonic acid that my team has shown over the years. Low levels of DHA that normally put the brakes on inflammation and form resolvins. And so it's this almost like perfect storm that maybe this is in part, probably not the whole answer, maybe this is in part why there's an increased cancer risk and increased tumor debris-driven cancer growth and spread. So maybe that individual that I presented earlier with pancreatic cancer, that FOLFIRINOX up front generates a lot of debris, still had some cancer cells around, and it just led to this perfect storm and very accelerated growth. If that's correct, that hypothesis, then we would expect the following. And this is the experiment that we did over the past 6 months or so. If you took a mouse and you take a normal mouse, that's a wild type mouse, you take a carrier, CF carrier mouse, that's the heterozygous mice, or you take a mouse it has overt CF and the genes are knocked out, and that's the CF mouse. And what we would predict, so this is hypothetical, what we would predict is that if you inject into the back of the mouse, under the skin, just the tumor, probably not much happens. If you inject it in a wild-type mouse, you're going to get a certain amount of growth. In a heterozygous mouse, we would predict a lot faster growth. In overt CF, even more accelerated growth. So that's the experiments that we've been doing here. Here's preliminary data. Hasn't been published yet, but we're getting ready to publish. So if you take a lung cancer and inject those cells under the skin, this is a wild-type mouse versus a carrier mouse. We're doing the CF ones as we speak. Here's the growth of the tumor cells underneath the skin in a wild-type mouse, 11 animals, much more accelerated in the heterozygous mice. Fits with being a carrier, increased growth of lung cancer. And if you look in pancreatic cancer in these animals, so we take separate group of animals, wild type, here's the heterozygous, 2.5-fold increased risk of growth of cancer cells. So it seems that, in fact, if you have some kind of CF defect, that leads to increased tumor growth here. So does that mean we should not give upfront chemotherapy like in pancreatic cancer? I think it means we step back and we shouldn't look at people with CF who are developing cancers being the same as everyone in the general population. So maybe we need to rethink what are upfront strategies. Do we give what's called neoadjuvant chemotherapy in the setting of pancreatic cancer? Maybe that's okay, but maybe not. What about if we increase resolvins? If we gave resolvins here or gave high-dose DHA, would that bring down tumor growth here? Would that, if you gave it up front, would that prevent cancer cells from growing? And those studies are ongoing actually as we speak here. So that brings us to the final part of my talk here. So treatment strategies. Obviously, we want to prevent cancers. If someone develops one, what should be a therapy approach here? And probably the last thing we want to do is just make everyone anxious here, but rather have a thoughtful approach. So, how can we be several steps ahead of someone going on to cancer and come up with strategies that really mitigate that? So one approach, and there's lots of different ways of thinking about this. This happens to be my area of focus. Uh, what about if we just gave high dose DHA EPA, so fish oil, to people with CF? Number one, we should probably make sure people are not on the old diets of, go to McDonald's, eat there 5 times a day, and have at least 100 grams of fat, and it's the crappy omega-6 fats. That's probably not a great thing to do. Um, so one thing I'll just mention it because people say to me, "Oh, I'm just going to take a whole bunch of fish oil and that will take care of things." Your body can only put in so many fat molecules. And by that, I mean, if you put in a lot of omega-6 fats, like you have, I think this is a Krispy Kreme cheeseburger. I can't believe anyone would eat it, but that does exist. And some people like it, I guess. But if you ate something like that, you get a ton of omega-6 fats. You can only put so many fats in the membranes of your cells. And if you put in all these omega-6 fats, you can take all the fish oil you want. It will not be incorporated and do its thing. So it's a ratio. So you need to probably take down these omega-6 fats, at least the amount you're taking in with our classic Western diet, if you want to get up the omega-3 levels. So, whoops. So one approach, and I'm actually have a study going on right now, non-CF, is what if you just take a lot of fish oil? I have nothing to do with Nordic Naturals. We've analyzed a lot of the fish oil, all the fish oils that are out there over the counter. Many of them are called oxidized, so they're shot, they won't work. We know Nordic Naturals is intact. So this happens to be what I take and everyone our team takes. But you can take high dose fish oil, 1.2 to 2.4 grams a day. If you take a baby aspirin, this will cleave most of it to the resolvins. It'll be anti-inflammatory, anti-cancer. Would that prevent and bring down the risk of cancer in people with CF down to what it is in the general population? Not sure. We're gearing up for this. If you're already developing cancer, would that shrink it? Non-CF, N of one, someone had reached out to me. Their dad is in Switzerland. We have treated him with very high dose fish oil and the SPM, the resolvins. He did not want to go to surgery, and his pancreatic cancer, along with an immunosuppressant, immunomodulator, I should say, not a suppressant, his pancreatic cancer has markedly shrunk. A little hard to believe. Pancreatic cancers never shrink. Maybe it's telling us this may be a potential strategy, maybe at least protective. And by the way, these SPMs, they help protect against Alzheimer's and dementia. They have cardiovascular action. This is work by a lot of other groups. They may be a diabetes modifier. So all the things we think about with CF and aging, they may help with that. Another approach is instead of giving DHA, EPA, just go ahead and give these resolvins. You can actually buy them, believe it or not, from Amazon. We actually have tested them. They are intact. I would not get Metagenics. It's actually pretty expensive. It is intact. And probably I wouldn't take it for the moment, but we have a trial that's just being activated looking at their action here. So, and looking like maybe this will be encouraging. So I'm going to end with this slide here. So who and when to screen? As I said at the very beginning, I think we just need to probably step back and just say, you know what? CF is a high risk condition, not maybe super high risk, but it's a high risk genetic condition. And we should just think about who we want to be screening and when, and just try to stay ahead of the game here. Which patients should we screen? What age? I think that's something we're all still trying to sort out right now. I think colonoscopy, definitely by your early 30s if you have CF. Not sure with carriers. My practice is I start usually age 35 in carriers, and that is in reimbursable by insurers. Doesn't look like highly effective modulators may be doing a lot, but does your CF genotype, your genetic mutation, how does that predict risk here? And how do we track our misses here? For people that develop cancers, what can we learn? That's health systems learning. And I've, talked about these other screening modalities that I think we're going to be learning a lot more in the next couple of years. MRCP, should we start doing that by age 50 to pick up precancerous lesions of the pancreas? Something called endoscopic ultrasound. Do we do screening for breast cancer at earlier stage, cervical cancer screening, HPV vaccination? And, what therapies? Should we just do what we do in the non-CF population? Probably not exactly. And as you see, we're learning rapidly, I think, a lot at the science level that I think will inform things here. And also things like diet makes a big difference. And I think that should not be kind of underestimated for our approach here. So I'll stop and happy to take any questions.